Sorry. Fauzi,
Dr. Shubhama, you can
chat
start.
box or
I
question
can start. Madam, I can start.
Yeah, you can start.
So, good evening, everyone. Today, our next, I think it is
Bhashati,
the
full screen
fourth
kora.
Oh, sir, ma'am,
NEBAOI classroom we are conducting, and we are very much pleased that Professor Pawan Singhal, HOD SMS Jaipur, has consented to be the external expert, and welcome all moderators and other participants of this NEBAOI classroom. So good evening all. So today our external expert is Professor Pawan Singhal. He is the senior professor and the gold medalist in MS ENT with the DNB, FSES, UICC, and international fellow of American Academy of Head and Neck Surgery, ISO, and John Hopkins Institute. He is presently working as a senior professor and head of the Department of SMS Medical College Jaipur and honorary secretary of AOI Rajasthan. He has served as a past secretary and president of NES, executive member of AOI, FHNO, and All India Rhinology Society. He is actively involved in social activities like neonatal hearing screening program and deafness control, anti-tobacco and cancer control activities, and free education for poor girl children. He has more than 70 articles in international and national journals and has innumerable awards and accolades of his credit, including the highest civilian award of State of Rajasthan by His Highness the Governor of Rajasthan. So I welcome you all, and I hand over this academic activities to the chairman and the convener of the NEBAOI classroom. Thank you all.
Dr. Anjan, may I request you to introduce our speaker?
Okay.
Dr. Anjan?
Anjan.
Good evening,
Dr.
everyone.
Anjan?
Yeah, can you hear me?
Yes.
Okay, fine. So, good evening. And our today's speaker is Dr. Bhashwati Mohondo. She is going to deliver a lecture on the ethico-enteral disease. So, this is one of the most common pathologies we encounter in our daily practice. And though we have been discussing this topic since long, so there is new things and there is something new to learn in every classes. So, Dr. Bhashwati, who will be delivering today's lecture. She is a senior resident in the Department of the Otolaryngology in AIMS, Guwahati. She did her master's from the Silchar Medical College, and she did DNBs in NBEMS. She was also working as a senior resident in Lakhimpur Medical College Hospital. So with that, I welcome Dr. Bhashwati for her lectures on ethico-enteral disease.
Thank you, Dr. Anjan.
Thank you.
May I request our Chairman Scientific Committee, Dr. Hironya Bora, to introduce our moderators, Dr. Gautam Khan sir and Dr. M. Niteshwar.
Good evening,
Hironya madam.
everyone. Good evening, everyone. So today I want to introduce our moderators. First, I welcome Dr. Gautam Khan as moderator. To introduce himself, Dr. Gautam Khan, he is working as a senior consultant in Nightingale Hospital and Pratiksha Hospital, Guwahati. And he's mentoring many doctors under his guidance till date. Mostly he involved in academics in several associations. Presently, he is president of Association of Phonosurgeons of India and governing body members of Indian Academy of Otolaryngology of India. I welcome Dr. Gautam for today's session. Secondly, I welcome Dr. M. Niteshwar. He is working as assistant professor, Caesar Hospital, Imphal, Manipur. I welcome Dr. Niteshwar for today's session. Thank you.
Thank you, Vaino. Now, Dr. Bhashwati, can you start your presentation?
Yes, ma'am. So thank you everyone for giving me this opportunity for this classroom, online classroom of NEBAOI. And so the topic of today is eticoenteral disease, pathogenesis, classification, and management. I hope this topic, since it is very important topic, I hope I give some light into the topic and help the PG students in their preparation. Okay, so eticoenteral disease. This is called eticoenteral disease because this disease is because of the anatomy, because it is specific to the location which affects the etic, that is the epitympanum, and the antrum, that is the mastoid antrum of the middle ear. Eticoenteral disease. The other name of the synonyms which are used are the unsafe, COM, or the dangerous, or the squamous. It is called dangerous or unsafe because it consists of cholesteatoma. So cholesteatoma has the bone eroding property, which is locally erosive, and because of that, this is very much dangerous and concern to the ENT surgeons. Classification based on the discharge of the ear, it can be classified in according to the inactive and the active. In the inactive, there are especially the patient complaints of the retraction pocket, which is present in the posterior superior part of the pars tensa, or the in the etic region, or the perforation of the etic region, and active when there is perforation and flakes of cholesteatoma are present. So what is basically cholesteatoma? It is a misnomer which is coined by the German physiologist Johannes Muller in the 1838. It is an erosive process consists like expanding lesions of the temporal bone, which is lined by the which is lined by the squamous epithelium, and accumulates the keratin debris. Incidence is
Sorry, Bhatsati, we are not seeing your slides actually.
so
Rohan, are you seeing the slides, Bhatsati
Yeah,
slides?
yeah, it is
Okay.
there. It is there.
Okay.
Yeah,
It
it's
is there. The
visible.
cholesteatoma is there.
Okay.
We can see. We can see.
should I continue?
Yeah, continue.
Okay, so incidence is 3 per 1 lakh in children and 9.2 per 1 lakh in adults. Then based on a Finnish study which showed that there is a male preponderance of the disease. Kervil here was the first who described cholesteatoma as the pearly tumor of the temporal bone. Abraham et al., he defined cholesteatoma as a three-dimensional epidermal and the connective tissue structure, usually in the form of a sac, frequently conforming to the architecture of the various spaces of the middle ear and the mastoid. This structure has a capacity for progressive and independent growth at the expense of the overlying bone and has a tendency to recur. Cholesteatoma can be classified according to the like origin, that is the congenital and acquired. Acquired can congenital is since birth, and acquired is primary acquired and secondary acquired. Primary is like there is no history of any otorrhea or any perforation, and it occurs and the presentation is generally the etic retraction pocket. Secondary acquired is secondary to the epithelial migration, or there is any like iatrogenically any because of some surgery it has been acquired. So congenital cholesteatoma, the term was given by the Derlecki and Clemis in 1965, who defined it as the pearly white mass, which is medial to an intact tympanic membrane, a normal pars tensa and flaccida, no history of any otorrhea, perforation, or any previous otologic procedure. Incidence is 0.12 per 1 lakh. Generally, the origin is basically, it's like there are the epithelial cell rest, which is like there in the embryological development, which led to the cholesteatoma formation, and the most common location in the anterosuperior quadrant. The presentation of the child is generally conductive hearing loss. So this is a structure of the cholesteatoma which we often skip and we miss. So it is like the outer covering is the bone, then the fibrous stroma, then the inner layer is the matrix, which is the stratified squamous epithelium, and the in the center there are the keratin mass. There are various theories of cholesteatoma. That is the invagination theory. The number one is the invagination theory, which says that because of the because of the dysfunction of the eustachian tube and the negative middle ear pressure, there is invagination of the squamous epithelium into the middle ear, which leads to the formation of the cholesteatoma. Then the basal cell hyperplasia, which says that because of the basal cells in the germinal epithelium, so they proliferate and lead to the cholesteatoma formation. Because of the invagination, also the retraction pockets they develop. Then epithelial migration is from the because of the like secondary acquired cases, there is perforation and epithelial migration occurs from the outer ear to the middle ear, which leads to the cholesteatoma formation. And there is also the metaplasia, that is the change of the mucosa into the squamous epithelium, which leads to cholesteatoma formation. When there is bone erosion in the cholesteatoma, certain mediators also plays an important role, such as the inflammatory mediators, the mast cells, the cytokines, and the enzymes, which actually leads to the osteoclastic bone resorption and the bone destruction, which is an important feature of the cholesteatoma. So clinical presentation, the patient comes to the ENT OPD with the complaint of may or may not have discharge, but the discharge which is there is generally said to be scanty, foul smelling, and mucopurulent discharge, and there is perforation generally in the atic region or in the posterior superior part of the pars tensa, or there can be retraction pocket in the posterior superior part of the pars tensa and the atic region. Then granulation tissues are often seen in the middle ear, and the polyp can also be seen, which is fleshy structure. And the patient consists generally complaints of the hearing loss, which is mixed type, that is conductive and the sensory neural. According to Scott and Brown, this table has been taken from the Scott and Brown 8th edition. And according to this book, in the patients of cholesteatoma, hearing loss is the most common presentation, which consists of 83%, followed by the otorrhea, which is 56%. This is different pictures of like eticoantral presentation. Here we can see dimpling of the I don't know if I can show you, but here we can see the dimpling of the dimpling in the pars flaccida. Then in the third and the fourth pictures, we can see flakes of cholesteatoma. Then retraction of pars flaccida. This is classified from the TOS by TOS et al. His classification is the standard, where in the stage 1 there is pars flaccida dimpled, and there is the retraction is not adherent to the tympanic membrane is not adherent to the malleus. Then in the stage 2, it is adherent to the neck of the malleus, and the full extent of the retraction can be seen. In the stage 3, there is partial erosion of the bony atic wall, and in the stage 4, there is almost complete erosion of the at least there is visible erosion of the atic wall. Along with that, there is retraction which can be like fully may or may not be fully appreciated. Then the management, the aim of the management is to relieve the symptoms of the patient as well as to minimize the risk of complications of the disease. So history of the patient is very important, and a thorough history should be taken from the patient. Then the microscopic examination of the ear is an important investigation which should not be missed. Here we should see the canal, the polyp, the granulation tissue should be appreciated, the perforation, the extent of perforation, the retraction pockets should be carefully examined. If it is a discharging ear, then culture and sensitivity of the pus should be taken and should be sent for examination. Accordingly, the antibiotics should be started if needed. Otoscopic examination also plays an important role, where the extent of the retraction pocket can be assessed, and in case of narrow EAC, we can do the otoscopic examination. Vestibular examination can be done, that is the fistula test should be clinically seen, and if the fistula test is positive and there is acute vertigo and nystagmus, then the semicircular canal fistula can be clinically diagnosed. Then hearing test also plays an important role. The hearing test in the form of pure tone audiometry should be routinely done for any assessment, as well as for planning the before planning any surgery. Imaging, that is HRCT temporal bone. Previously, X-ray mastoids were used, but now with the advent of CT scan, HRCT temporal bone is an important investigation for the ENT surgeons, where we can see the bony erosions and the extent of the disease, as well as pneumatization of the mastoid can be appreciated. Diffusion weighted MRI can be is an important investigation, and it differentiates between the cholesteatoma, inflammatory tissue, and the brain in case of residual disease, also in case of recurrent cholesteatoma. So this is a CT scan where we see in the left side there is no erosion of the scutum, whereas in the right side there is erosion of the scutum is appreciated. So coming to the treatment, the only effective treatment is surgery in case of cholesteatoma. So the aim of the surgery should be like eradication of the disease. Then there should be a epithelialized mastoid cavity. There should be a self-cleaning ear, and we should minimize the risk of recurrence, and the surgery should improve the hearing of the patient. Conservative management, such as the topical medications and the routine suctioning of the ear, should be done, especially in case of the unfit people for surgeries, where surgery cannot be done, or surgery because of some other comorbidity, surgery cannot be done. Then mastectomy is the surgery of choice. So what type of mastectomy to be done, it depends upon the extent of the disease, the preoperative health of the patient. We have to see whether the opposite ear is functioning or it is not functioning, and generally mastectomy depends upon the type of mastectomy, which one to choose. It obviously the surgeon's expertise also helps in that. The surgeon who are very much expert, and they can many people are doing endoscopic approaches of mastectomy, where transcanal approaches are done endoscopically, and mastoid clearance are done. So definitely experience matters. Then the absolute indications of the mastoidectomy, especially canal wall down in case of cholesteatoma and the tumors, and the relative indications are in case of history of profuse otorrhea, then previous failure cases in case of sclerosis of the mastoid, and in case of secondary acquired cholesteatoma. My slide is not moving. I don't know what happened.
Close it and again start it. Close the PPT. Come out of the full screen.
Yes, I hope you can see the slide, ma'am.
Yes, yes.
So
Yes, we can.
canal wall down or canal wall up, there are two mastoid we can broadly categorize. Then canal wall up, the like in case of mastoid, in case of canal wall up procedures, what happens is like the posterior wall of the EAC is retained, so the natural anatomy is retained. It heals quickly, and it do not require the regular debridement and the regular follow-up. And the hearing is definitely better in case of canal wall up. In canal wall down, recurrence is a factor than easy assess recurrence sorry. So recurrence is less in case of canal wall down, then easy access to the epi and the mesotympanum is definitely there, and increased visibility is there. So canal wall down and up both has its own pros and cons. In canal wall down, the surgeries which comes under is like radical mastoidectomy and the modified radical mastoidectomy. Generally now modified radical mastoidectomy is done not radical. It is like with the advent of the modern surgeries, modified radical is preferred over radical. At least some hearing can be given to the patient. Then canal wall, in canal wall up surgeries, etechotomy is like done when the disease is limited to the atic region. Then etechoantrostomy can be done when the disease is limited to the atic and the mastoid. And combined approach tympanoplasty when the disease is extending to the mesotympanum, then through the posterior tympanotomy approach, disease clearance can be done. So just I want to give a brief like how mastoid surgeries are done for the PG students in case they have any doubt. Like first we have to like prepare the patient, draping, then post auricular incision is made, which is shown in the left side. Then in the right side, incision of end oral is shown, where like especially in case of endoscopic surgeries of the where etechotomy is performed endoscopically or transcanal via the limited disease, then end oral approach can be done. This is a marking of the vascular strip of the canal, where it is incisions are given over the petro squamous and the pest where just a minute, where bleeding is less. Then this is like after giving the incision, soft tissues are retracted, and we can harvest the temporalis fascia graft, where it is shown in this figure, where temporalis fascia graft can be used for the canal reconstruction as well as for the tympanoplasty. Then so like after soft tissue retraction, spine of Henle is exposed, which is one of the important landmark. And then along with the spine of the Henle, here posterior wall of the EAC, then this is the linea temporalis, and this is the mastoid tip. So this line and this line, a tangential line joining both of them, that forms the McEwen's triangle, and drilling should start in the McEwen's triangle. And it is said that 1.5 centimeter deeper to the McEwen's triangle is the mastoid antrum. Then mastoid antrum should be opened, and we should see here in the lateral bulge of the semicircular canal. And once the atic area is reached, a short process of incus is appreciated, which we get to know that the atic area has been exposed. So if in the canal wall up, where the approach, where the disease is in the mesotympanum, then facial recess approach can be done. Where the landmark is the superiorly there is the incus buttress, and posteriorly there is the facial nerve, and the anterolaterally there is the cauda tympani nerve. And myotoplasty is an important step in the mastoid surgery, where epithelialization of the mastoid cavity is very much required, and like for the cleaning and toileting of the ear later, to enlarge the mastoid cavity, we need the myotoplasty. Generally, conchomyotoplasty is done. Then the post-op care, mastoid dressing should be applied in case of, especially in case of canal wall down mastoidectomy. Then facial nerve function is tested. Ear water precautions should be explained to the patient. No straining, coughing, and forceful sneezing should it should be advised to the patient. Gentian valet is often used on the granulation tissue in the mastoid cavity for proper healing and epithelialization, and follow-up of the mastoid patients is definitely important. Complications of the eticoantral disease. It was Morgagni who said that ear infection leads to the brain abscess, and brain abscess is the first complication which was discovered in the literature. Then the factors which helps lead for the complications of the eticoantral disease, the factors which are responsible are the virulence of the organism, then sensitivity to the antibiotics, and the host resistance. And definitely immunocompromised patients, they have a risk of the complications of the eticoantral disease. Then pathway of spread of complication is mostly by the bone erosion, then direct extension through the natural pathways, and the thrombophlebitis. Signs of impending intracranial complications such as the pain, high-grade fever, altered sensorium, photophobia, neck stiffness, generalized malaise, and persistence of otorrhea. Intracranial complications such as meningitis, brain abscess, otogenic suppurative thrombophlebitis, otitic hydrocephalus, subdural empyema, and epidural abscess. So briefly, I'm going to tell about the complications. So like meningitis, the chief complaint are the headache, fever, photophobia. The severe form of headache is there in case of the patient, and there is high rise fever. Then photophobia, irritability, and the restlessness. Clinical signs such as Kernick's and the Brudzinski sign, they are positive. CT scan and MRI do help us in investigating these cases. And apart from that, radiological investigations, CSF analysis, and culture should be sent. And with the advent of the antibiotics, now third generation cephalosporin and vancomycin are the drug of choice for the meningitis. In case of brain abscess, it is a focal suppurative process within the brain parenchyma. Then the patient generally complains of the headache, bony pain, they are toxic looking, high-grade fever, and the focal neurological deficit. Investigations to rule out other CT scan and the MRI. The patient should be hospitalized, and high dose antibiotics are given, and excise and drain of the abscess is necessary when the conservative management fails. Stages of formation of the brain abscess is important, such as in the early cerebritis, it takes place in day 1 to 3. Then the late cerebritis, 4 to 10 days. In 4 to 10 days, early capsule formation in 10 to 15 days, and then late capsule formation in 14 days. So autogenic suppurative suppurative thrombophlebitis. The patient will have high grade of fever, which is the typical, the term which is used is the Pickett-French fever, where there is high fever and it doesn't reach the baseline. Then there is proptosis, ptosis, chemosis, and ophthalmoplegia. Grisinger sign, which is positive. Then Toby Ayer test is positive, and imaging, CT scan and MRI to be done, where in CT scan delta sign is positive. Then surgery is treatment of choice. In case of otitic hydrocephalus, benign raised intracranial hypertension, raised intracranial pressure, there is normal CSF finding and spontaneous recovery, and there is no abscess. So headache, drowsiness, vomiting, and blurring of vision and diplopia are the features of the patient. MRI is the investigation of choice, and in the management, CSF drainage and optic nerve decompression can be done. In case of subdural empyema, which is a rare complication where collection of pus between the dura and the arachnoid matter, headache, fever, and vomiting are the complaints of the patient, and MRI is the investigation of choice, and it is a surgical emergency. Epidural abscess is the infection of the space between the dura and the bone. It is also a rare abscess, which is a rare complication, and management is exploration and drainage. Intratemporal complication consists of the acute mastoiditis, where there is pain behind the ear, then fever, ear discharge, and mastoid tenderness. Investigation is CT and MRI of the temporal bone, and the treatment is IV antibiotics and surgery. There are various, along with the acute mastoiditis, patient also complains of the mastoid abscesses. So there are certain abscesses which are important for the JRs, that is the zygomatic abscess. Then there are Chittelis abscess, which is the post-auric behind the mastoid. Then basalt abscess, which is along the line of the sternocleidomastoid. Then petrositis, which is one of which is also a complication where the patient complains of the fever, headache, vomiting, and there is Grady-Nigo syndrome, which is like persistent ear discharge, fifth and the sixth nerve palsy. Then CT scan and MRI are the diagnosis of choice, and treatment is systemic antibiotics and surgical drainage. Facial nerve palsy can also be a complication in the intratemporal, where CT scan and MRI are the investigation of choice, and management is antibiotics, then steroids, and facial nerve decompression. Labyrinthitis, which consists of the serous labyrinthitis, autogenic suppurative labyrinthitis, and the meningitic suppurative labyrinthitis. Clinical features, it is transient vertigo, and treatment consists of systemic antibiotics and mastoid exploration. Complications of the mastoid surgery consist of the facial nerve injury, then the intracranial injury, then mastoid. In the mastoid surgery, there can be hearing loss, because of the extensive disease. Then there can be infection because of the surgery. There can be infection if proper cleaning and proper hygiene is not maintained by the patient. Post-op, proper patient doesn't come for the follow-up. Then vertigo can be one of the complication of the mastoid surgery if patient ossicles are eroded, or ossicles have been not reconstructed, and ossicles erosions are there. Then canal defects, because of the canal, one of is canal defect, and bleeding can be there. Okay, so these are my references. Thank you.
Thank you, Dr. Bhaswati. May I request Dr. Singhal, please give your comments on this presentation. Dr. Pawan Singhal.
Yeah.
Sir.
And mute myself. Is it okay? My voice is there?
Yes, sir, we can hear you.
Yeah.
We can hear you.
I thought it is going to be a class case presentation. Okay. So nicely done.
It was not a case presentation, sir.
It was a class. It was a class.
It was like
class. So I'll suggest you something, Bhaswati. Please don't use the term like etiquette disease or mucous or this safe or unsafe disease classification now, because throughout the globe now people are using like mucosal disease or squamous disease. It could be acute active mucosal disease, inactive mucosal disease, active squamous. So active mucosal disease when there is a perforation with discharge, infection, active infection. In active mucosal disease, you do have a perforation, not discharging. Then in squamous disease, you do have active squamous disease where you could objectively find some cholesteatoma flakes, maybe by the autoendoscopy or open eye examination or with the EUM, that examination under microscope. Inactive squamous disease is just a retraction pocket. Then fifth category, which comes as a healed perforation or a temporal sclerosis. So this classification should be used now. Okay. And this recurrent and residual cholesteatoma, Dr. Fukan has been writing his comments there on the message box. This is basically known as recidivism. Use the recidivism for any recurrent or residual cholesteatoma. Believe me, there is never a recurrent cholesteatoma. It is the residual cholesteatoma in the first go, if you are talking about a recurrent setting. Usually it is a residual cholesteatoma. So for decades together, we have been talking about cholesteatoma. And now Abramson has given such a wonderful definition of cholesteatoma. I think it suits to its characteristic. That is, takes the shape wherever it goes. It expands with erosion of the bone and compromising the structures there. Okay, so whatever structure there, if it is a very erosive, one more thing which is coming about cholesteatoma is biomarkers. You have not talked about biomarkers there. I would have loved to see a few slides about cholesteatoma biomarkers. Can you elaborate if you know something about biomarkers? I know it is not an examination. I'm sorry for that, Baswati. But just to enlighten the younger colleagues out there, just to enlighten their academic acumen, some biomarkers are there which are being studied so much these days. We have done a study there at our department also.
So is it Ki-67?
Yeah. So there are biomarkers for creatine. There are biomarkers for your metalloproteinases. Okay, for squamous pearls and all. So you do have creatine biomarkers, metalloproteinases biomarkers. Then Ki-67 you do have. So there are a lot, and then you do have for tumor necrosis factors, alpha and all. These biomarkers, they tell you the property of this particular cholesteatoma. Like if you talk about metalloproteinases. So these metalloproteinases do have capacity to erode bone more as compared to the biomarkers for creatine, which has got a propensity to give squamous pearls more and more, squamous epithelium more and more expanding sac. But metalloproteinases, they erode it a lot of times. More erosion rather than that. Then you do have IL-1, IL-6, you do have alpha tumor necrosis factor. They cause more and more granulations because they are inciting more and more angiogenesis and inflammatory markers to be aggregated over there. So that's why you sometimes in a few patients you get granulation along with the cholesteatoma. In a few patients, only retraction pocket cholesteatoma. In a few patients, expanding cholesteatoma with a lot of matrix inside. That depends on these biomarkers. So this is something new thing which is going on. So in the first go, there might be time in the coming era. You take a swab, send it for biomarkers, and you get to know that how it is going to react in the future. So you
Are
can plan
you doing, sir, biomarker testing in your institute?
I'm not doing right now because it is not freely available. They are costly. But you can start practicing it with a few cases, sample cases, or you can do because you are in a premier institute, AIMS now. With Brian, I know Brian is there. So
Yes,
you can start giving it like a thesis to one of your resident so that you can subject some cases to these biomarkers. You can get a good study. Okay. So at AIMS, you can get all these biomarkers available. You can get a project, you can get an ICMR project or DST projects, sort of. Correct?
Yes, sir.
So anything else? I think Gautam sir?
You have summed up what Baswati has left behind. Baswati, it was a good presentation, but let me point out certain small things like what Pawan has also said. Number one, there was a small mistake of retraction your spelling was wrong. But there you said the patient complains of retraction. Patient never complains of a
Never
retraction
complained.
pocket.
I could
Yeah.
make it out.
And-
Yeah.
Yeah. Second, you said about DW MRI. It's for detecting cholestoma. It's not simply DW MRI. It's non-EPI DW
Yes.
MRI. You have to be specific there. Then regarding the type of surgery,
Let's
canal wall up, canal wall down. Yep.
there is a gold standard of for cholestoma is still your HRCT, temporal bone.
Yes.
But to differentiate between a few things, if you are confused about the things, you are seeing some erosive pattern, there is a soft tissue density. It could even be something like inflammatory myoblastic tumor. It could be histiocytosis X. Got my point? So then you have to differentiate. Or it could be even paraganglioma sitting there in the middle ear. So in those cases, if you are not sure and the patient's symptomatology does not match with the radiology, like extreme pain, there is no pain in cholestoma usually, unless it is eroding over the nerves, basically the tympanic nerve plexus. So in such cases where the symptomatology is not matched with your clinical finding and CT is not giving much information, you should get an MRI done. Got my point? So there are some scenarios. You can perceive some sinister thing going in. Bleeding, deep boring pain, or excruciating pain, or some pale granulations. You want to know about the things. So then, okay.
Yeah, regarding the type of surgery, you commented about many things, but the patient factor is also very important.
Yes.
Whether you are going to do a canal wall up or canal wall down, because if your patient is not going to come for a regular checkup, there's no point thinking about a intact canal wall situation, because you may have recurrence. You have to convince the patient about going for repeated MRI, maybe a second look, etc. Of course, you spend a little less time on myetoplasty. Probably it deserved a little more importance, because the surgeon always gets tired by the time he is doing the myetoplasty. So this is one of the most crucial points of the surgery.
And Gautam sir, when you talk about patient factors, I always teach my residents there are 3 factors you should always think of before starting any treatment: patient factors, disease factors, and physician factor. Suppose your patient has got extensive cholestoma. Suppose it is limited cholestoma, but it is going towards the adductus and atic. Got it? But if you are a naive surgeon, a new surgeon, you don't know how to do an inside out and then reconstruct. So that is something limited with the physician factor. Got my point? Then you do have symptoms of intercranial complications, but you are sitting at a community health center, CSC, and you can't have a CT scan or a MRI to know about intercranial, but you are thinking of that. So that comes under your hospital factors ki aapke paas you do have facilities or not. And sir rightly said, your patient is coming from a remote area, can't travel you again and again. Do something in one go. If cholestoma is there, canal down. So at least no recidivism is there. Try to give a good hearing. That is a secondary objective. The primary objective is to prevent complications and give a safe ear. Secondary is to give some hearing. Third is to keep it dry. And fourth is manageable ear for the patient. That's where myetoplasty comes as a pivotal role. Do a good myetoplasty from which you can inspect the patient, from which it can drain back, but not a disfiguring one, large one, triangular disfiguring. Don't do that. It should be something from which you can pass your finger. That's it. Don't compromise much of the cartilage. You won't like to have it in your ear. Someone from a 25 meter, 20-meter distance can say, oh, she has got a big hole there in ear. No, not like that. A good myetoplasty that should also be cosmetically appealing. I presented my 5-flap myetoplasty many a times, even in sir has seen in many conferences. So maybe next time I can join you guys and show you some techniques there. Thanks.
Nitesh sir, would you like to add something?
Sir, if in a situation like ours, second look surgery is something very, very impractical. People felt it very, very difficult to, to go for second look surgery. So as long as, personally, what my experience is, as long as you can do in one stage, with canal wall down, osteoplasty, clearing all the disease, everything, I think I prefer doing that. And regarding, I just wanted to add, the temporalis fascia was taken in the early part. Personally, I would like to differ a little bit, because temporalis fascia I always take in the last part, because you know how much extent or how much big your temporalis fascia will be, and above that it should be a fresh. I prefer actually. There are many different opinions about it, whether it's a dry one or a fresh one. Again, regarding the technique of mastectomy.
Can I comment on temporalis fascia?
Sir,
Right?
sir, sir.
So you are absolutely right about temporalis fascia. The old thoughts of having macrophages engulfing all fascia, it goes, and only the two layers remain. This is wrong.
This is absolutely
People
wrong.
used to
I
think
agree with you.
that
I agree with
temporal
you.
fascia is just giving a scaffold surface
Yes,
for epithelium
yes.
to grow and
Mm.
lamina propria, that is mucosal layer, to grow under it.
Yes,
But
yes.
believe me, if you if you are doing a revision surgery, it persists there. So
Exactly.
I prefer doing a total annulus excision surgery, where I remove all the annulus with residual tympanic membrane. A nice trimeric tympanic membrane forms, which has got an
Absolutely.
epithelium, a fascia, and then lamina propria mucosal layer inside.
Mm.
So
But
that's
I also don't prefer, sir, dry temporal fascia. I never use dry.
the second thing. When you take a wet graft, immediately when you are putting in, it has got a good, nice activity remaining there.
Exactly, sir.
Take some
And,
additions with some.
sir, while taking decision of whether to do a canal wall up or a canal wall down, sir, we also need to know the physiological aspect of surgery. All your surgeries are anatomical based, but right now it is changing to physiological aspect also. So the physiological aspect becomes very, very important, because my personal experience also, I have seen it. I have seen two cases of not a residual disease, it's a recurrent disease, but the middle ear was pristine after the surgery. But then I did a soft wall reconstruction, and in that I made a mistake of not preserving the mucosa, and that has caused a retraction in the mastoid cavity only, not in the middle ear. So this
One
taught
comment
me a
there.
very, very important,
One
very, very
comment there,
important lesson.
if time permits. There are two ventilation systems working in ear.
Exactly.
One is the Stegan tube, and one is your mucosal system in mastoid ear cell system. So in most of the cases, I go inside out. I follow the disease, take out the disease, leave the breathing mucosa intact in the mastoid, and reconstruct the posterior superior canal wall or atic. This is how, because why retraction happening? Your Stegan tube not functioning well. You can't regain that by any method. So you have to keep that breathing mucosa intact. Even if you are doing a combined approach intact canal, please do not knock off the medial part of mastoid mucosal system. Leave it.
Exactly.
Just take a ball probe, take the cholestoma sac with the ball probe intact, and leave that mucosa, and it is going to give you a good breathing middle ear cleft.
Again, sir, if we are expecting a dry ear, then one thing I always follow and do judiciously is, as much as mucosa should be removed if you are going to do a canal wall down, because that mucosa, when it grows, it gives
Canal
to
wall, you
both
have to
ears.
do that.
It has to.
Radiation is being done by the mucoplasty.
Yeah, I have seen, sir, many people not removing the mucosa, and many a times I have seen the wet discharging cavity all the time. And then we will use Jensen bile, all those acetic acid, everything. But then the pristine result comes when maximum is, I would say, all of the mucosa or maximum of the mucosa has been removed. Let the epithelium grow over that. instead of a mucosa or a patches of mucosa growing over. Sir, again, I've written some of the points. I don't know. Osteocloplasty. Sir, I always do a cartilage osteocloplasty. Of course, it has got one drawback I have seen. The amount of hearing we are getting is little bit less, but this is a compromise that I usually add up instead of having a a prosthetic, an artificial prosthesis, and getting giving a chance of exclusion. So I have not come across any exclusion from a cartilage, and it should not be. So would you prefer? Would you still
Here I'll
prefer
tell
a
you something. I
prosthetic or a
think
cartilage?
Gautam sir would also have seen this. I was using these prostheses, even the Teflon and this titanium. Since 2010 to 2015, I did a study. I used to see my own patients coming with this extrusion.
Exactly.
Then I started putting a cartilage. Still not better.
Exactly. Still,
Then
sir.
we started doing 2-3 methods. One is vertical strut. I've also published it in journal RCT, a randomized control trial, using a type C intact over the steppies and using a vertical strut. This is very hard. You take it from the floor of the concha.
The floor of the cartilage, yeah.
To make a wedge, triangular wedge, keep it on the foot plate, even if your intact steppies suprastructure is there. Because usually that intact steppies suprastructure is not giving you a middle ear height. And it might be like this. So angle is different. Your tympanic membrane is coming off on sideways. So when you put in a vertical strut, it makes an association with the foot plate as well as the suprastructure if it is intact. And it overshoots the sulcus annulus a bit. Initially, for a few weeks, patient might have vertigo because it overshoots. But believe me, I have seen total AB closure in most of my patients. The second thing, when a good steppies is there, but the position is not good as this, and intact malleus is there, I use a boat cartilage. A piece of cartilage, make a groove for steppies head and make a groove for malleus on the superior surface, groove for steppies on under surface, slide it between the steppies and malleus, you will have good hearing. That is the second way I do it. I never interpose anything between the incus and steppies if lenticular process. If lenticular process is gone, please remove this incus. This is a disease incus. Don't try to do anything between it because it will carry on giving necrosis of incus upwards.
Sir, your opinion about bone, the intact incus using as osteocloplasty material?
Nitesh,
I don't use it.
there are some questions in the box. Can you take it along with this your discussion? It will be better.
So
molecular ma'am, there are some
marker. Then we can,
already
we
done.
can discuss with this. AK and Belusis and Mary. So Mary index is there, which people are using. It's up to you. If you want to use some index for pre-operative scenario to match with your results, you can use these indexes. What is the gravity of the disease and how I'm gonna do the best of the, give the best of the results to the patient. Then comes your SADEs and classification. I think she has already discussed. Eosinophilic chondritis media is something different. You have to take a biopsy, prove it, and treat accordingly. Recidivism we have talked about. Is vestibular function assessment necessary in this active squamous disease? If patient has got tinnitus or has got vertigo, then as such with the imaging you will get it. But if the imaging does not match with these symptoms, you can get vestibular system test done. Maybe VNG and all. Molecular marker we have discussed. Biofilm in active control disease, I have not seen yet. But if it is a resistant discharge, you can get a culture sensitivity done. And empirically, you can use clarithromycin. I'm telling you. That helps a lot. And believe me, people are not using much ciprofloxacin. I am still using ciprofloxacin. It works well also to Manas. Then if nothing is happening, nothing is working, I'm using cotrimoxazole, and patients are good. Cotrimoxazole with amikacin, eye drops preparations are there. You can use an ear drop. That helps. Then comes obliteration. Yes, if uh, if you're going inside out, you are obliterating it, or you are using a cartilage. If you have done a big cavity, it is going to cause a lot of cavity troubles. You can use local flaps, or if no hearing is there, no serviceable hearing, you can do a subtotal petrosectomy and cul-de-sac closure. But in that scenario, if patient can afford, you can do a cochlear implantation or maybe an osseous implant to such patient. And then comes your, that is, I think mucosal fold. We can do it with that, Thanks.
Sir, you have done my work as well. Thank you, sir.
Thank you.
Thank you, everyone. Very nice discussion, very beautiful discussion, fruitful. So, any questions from anywhere? Anyone want to ask anything?
Regarding the Austin cartilage ossicular plus the ossicular reconstruction sort of thing, I think it's always good to, even if you don't write it in the AK structure, it's always good to write down what has been done. Many a times we often see MRM done or mastoidectomy done. That is a sort of note people come with. That is very bad, actually. You should have because this is something the patient lives on for his whole life. So when somebody does a mastoid surgery, wall down or wall up, I think the patient should have a detailed note about what operation was done, what sort of reconstruction was done, what was used, because this should be a habit with all of us. If you can follow the AK classification is good, because you can correlate very easily, just like for facial nerve, when you write down the Brackman score. Even Singhal gets my patient, he will know what was the Brackman score at that point of time.
I think this is very good take-home message. We should write the notes very well, because if patient goes to someone, he knows what has been done, what was the disease scenario, what the surgeon has done, so that he can match with the things. That is very important.
Sir, we should also utilize.
It should be uniform classification. That's
The
what we are doing
classification.
in cancers. And we are following TNM. We are going with the AJCC criteria and all those NCCN guidelines and all. They are uniform guidelines. So we can have uniform guidelines for here also. But
Sir, there are two, three guidelines, like poly classification, and some classifications are there where it describes the areas involved, the things that have been done.
Sure, but the thing is, the most important thing, whatever you have done, please write it down in the discharge ticket.
Exactly, absolutely.
Thank you very much.
Madam, I just wanted to add one thing. Sir, if there is a semicircular canal dehiscence there, so how would you prefer to reconstruct? I mean, the layers of reconstruction. Wow, what I used to do is I put bone dust over that, and then over that fascia, and then covered by this temporalis fascia. This is how I used to do, because some people just simply keep some fascia, some people just leave it also. What I felt is, madam, once you put bone dust and let the bone cover that area, then the future chance of a fistula, I mean the fistula sign or the change in the pressure that gives vertigo is minimized or decreased.
You have to see to it that endosteal layer is intact. If endosteal layer is intact, you can use a bone dust over it and then put a fascia. Got it? But if it has been perforated through and through, if you put in bone dust, it might be a foreign body for the canal. Patient will have BPPV.
Yes.
So in that scenario, use soft tissue to obliterate that particular point. Soft tissue, put in, obliterate that particular area, a bit inside, then put a fascia. But if it is a large opening, you are just putting a fascia, you are giving a fistula.
Exactly. Yeah. Sir, one second, before time finishes. I've seen many people using a simple muscle. I mean, it's not a pedicle muscle, a simple muscle to obliterate certain, like near the sinodural angle, in certain parts.
Not done. Should not be done.
I am very much afraid of the risks of
You can use fat, but not muscle piece.
muscle. I've seen many renowned people doing it.
You do have so many muscle flaps are there.
Exactly.
Inferior flap. You do have superficial temporal base, anterior flap. You can rotate like inside. So many. So both the flap go in suture back.
Yes. Yes. But then the muscle, if we keep it like that, how will it grow? From where the vascularity will come?
That is stupidity. If you put a free muscle, just a free muscle, that is stupidity.
Yes.
It's not going to survive on bone.
Yeah, the reason I wanted to confirm that one, because I've never done it. I'm afraid of that muscle getting died and then acting as a photobody or a nidus of an infection later on.
Yes, certainly.
Thank you very much. I don't want to stop it, but we have time limitation. So thank you very much. This is time for vote of thanks. Good evening, everyone. On behalf of the Scientific Committee NEBAOI, I extend my sincere vote of thanks to all who made today's 5th NEBAOI classroom success. I would like to express our heartfelt gratitude to our expert, Dr. Pawan Singhal, for sharing his valuable insight and enriching us with his vast experience. Thank you, sir. Our sincere thanks also goes to our speaker, Dr. Bhaswati Mahanta, for her excellent presentation. We are equally grateful to our esteemed moderator, Dr. Gautam Khan and Dr. M. Niteshwar, for conducting the session and guiding the discussion. It was a very beautiful discussion and vast discussion, very helpful for everybody who will be helped here. I also thank all NEBAOI members and PG students for their active participation, which made the session interactive and meaningful. Thank you all. Have a pleasant evening. Thank you very much.
Thank you, Dr. Bhaswati.
Thank you very much.
Thank you, Pawan.
Thank you all.
See you soon.
Very good.
And
good.
all the best for your IOHNS.
Dr. Pawan.
I'll request everyone to please join Indian Academy Conference.
Yeah.
It is a true academic conference, informal meeting. I have 5 halls which will work from 8 a.m. till 6 p.m. all 3 days. I'm telling you, it is gonna be one of the best academic meeting you will have. And I do have 6 hours innovations, IPR, and patent session. People who do have innovations, IPRs, patents can apply for that. We do have awards for that. And you can get young brains there for new ideas to grow the science.
Yeah, Dr. Pawan, so as you know that the RhinoCon will be organizing in October.
Yeah.
That will be on the 30th, 31st and the 1st of November. So I sincerely invite you and all your colleagues along with all the fraternity members, everyone to be in Guwahati in October last.
I would certainly love to join.
And put your all ideas, all the everything, whatever you feel like. So you can share with us. We'll go and we'll have.
I love operating anterior skull base and central skull base tumors.
Yeah. Right. So we definitely want to hear you, and we'll invite you for that same.
Okay. Thanks.
Yeah.
Thank you.
Thank you.
Thank you.
Thank you, everybody. Thank you. And
See you in the next meeting.